first class regarding about the local anesthesia. So in this topic, we are looking about the pharmacology of local anesthesia. What are the techniques used for the maximum mandible and the complication. In this topic, the learning outcomes will be the first, what do you mean by LA, and how the physiology of the nerve conductions, classifications, biotransformation, how the body will absorb and excretion, these things. Later, the topics will discuss about that the contents of LA, mechanisms of action of LA, what are the techniques we will use, everything. What do you mean by local anesthesia? It's a transient loss of sensation in the subscribed area of the body produced by the depression of excitation of the peripheral nerve endings or inhibition of the conduction process. So, it's defined as the loss of sensation in the subscribed area of the body caused by the depression and excitation of the nerve endings or inhibition of the conduction of the process in the peripheral nerves. So, what's the history behind of LA? So first, they started in the in South American Indians. Then Albert Neyman in 1850 prepared extract from the plant. He noted the altered sensation of his tongue on chewing the leaves. And later on, there are a lot of people like Ludwig, Dr. Schultzka, Dublin, like that. A lot of people said found out. And Niels in Lord Frank, 1943, first seen by the lignocaine. And later the other people say found out, and the first William student Halstead approach came for the inferior nerve, and in 1940 will be the lignocaine, and 1946 lignocaine introduced in the dental practice. So what's the actual indication for the local anesthesia? Most frequent use in the regional anesthesia and analgesic, especially most operative pain, and lignocaine can also reduce the blood pressure response to direct laryngoscopy drug intervention, like that. So there are two types of anesthesia. One is local and one is general anesthesia. Local anesthesia, the site of action is only the peripheral nerves. The area is restricted, conscious not altered, unaltered, and it can use for the minor or surgical procedure, and it is safer and the care of vital function not needed. But compared to general anesthesia, it acts on the central nervous system, acts on the whole body. Loss of consciousness we can use only for the major surgical procedure, and it will be little risky, and care of vital function is important. So how will you classify local anesthesia? Based on the chemical structure, ester and amide, and based on the mechanism, long, intermittent, and short time. So there are injectable types are there. Injectable like low potency, intermediate, high potency are there. Short duration, intermediate, and long duration. Short means we're using procaine, chloroprocaine. Intermediate by lidocaine, prolocaine. High potency like a tetracaine, bupivacaine we can use. Surface type of anesthesia like soluble and insoluble are there. Soluble like cocaine, lidocaine, tetracaine, like that. Insoluble like benzocaine, oxazine. And other types like a chloroil, phenol. These are not commonly used, but commonly what we are using is lidocaine, like that only. So according to the ester classification, there is butadiene, cocaine, benzocaine, pyrrolocane, tetracaine, and amides like articaine, bupivacaine, lidocaine, bupivacaine, pyrrolocane. These are the amide types. So what's the fundamental of neurotransmission? Already you know about the nerve cell and the dendrites, nucleus, cell body, axon, axon terminals, all these things. So how it acts on the LA acts on the our body. First thing, step 1, that is when the nerve is stimulated, the membrane becomes transiently permeable to sodium ions, which across the neuron membrane through special spores. pores in the membrane called sodium channel, and it's related to the depolarization. So this is called the threshold potential or firing threshold. You can see in the diagram. And after that, then the electrical potential is reversed, resulting in the inside the body nerve electrically positive and outside become negative. We can see in the diagram. Second, step 2, in the sodium channels go coming inside now, so there will be previously it is positive, and the step 2 become negative. There is a potential waiver. And what will happen then? The phase of depolarization, electrical potential will become more negative inside to outside until the voltage of -70, like that. So first there is the what will happen, the LA interact with this receptor within the voltage sensitive sodium channel and raise the threshold of the opening of the all channels. Then sodium permeability decrease and ultimately stop in the response to stimulus or the impulse. Impulse conduction is interrupted when a critical length of the fiber is blocked. So high concentration of the calcium reduce the inactivation of sodium channel, and blockage is not due to the hyperization. Blockage is related to the acid dissociation constant. So mostly the lignocaine pH is 7.6 to 7.8, and ibuprofen is 8.1 to 8.9, like that. So this is happened. You can see on the diagram how it's open and how it's become closed to the potential. So action of LM is blockage of sodium channels, decreasing the sodium conductance, depression of the rate of electrical depolarization, failure to achieve the threshold potential level, lack of development of the propagated action potential, and the conduction blockage. So the mechanism of action again I tell you. First, the inhibition of excitation of the nerve endings or blocking conduction in the peripheral nerves, binding to and inactive sodium channels. So LA are alkaloid bases that are combined with acids, usually hydrochloronics, to form water-soluble salts. All the anesthetic salts uh, are formed by the combination of weak base and a strong acid. So it's a stable and soluble in water, and water solubility is necessary for their diffusion through intestinal fluids to the nerve fibers. So the sodium influx through these channels is necessary for the depolarization of the nerve cell membranes and the subsequent propagation of the impulse along the course of the nerve. When the nerve loses the depolarization and the capacity to propagate the impulse, the individual loses the sensation in the area supplied by the nerve. Block the nerve conduction by acting on the nerve membrane, inhibit the sodium activity, blockage of the blocks the depolarization, and blocks the nerve conduction. This is the mechanism. There are various theories of mechanism of action of LA is there. One is the membrane expression, specific receptor theory, calcium displacement, acetylcholine theory, like that. The acetylcholine theory, that means involving the nerve conduction, is an addiction to its role as the neurotransmitter and its nerve synapses. But calcium displacement theory is LA causes the nerve blockage, the displacement of calcium from some membrane site that controls the entry of sodium. Surface charge or the expansion theory is LA are lipid soluble. So enter the nerve membrane and changes the configuration of membrane. There are thereby reduced space of the sodium to enter, thus cause inhibition. And the surface charge theory is action by binding the nerve membrane and changing its the electrical potential. Specific receptor theory is the hydrophilic charged amino terminal binds to specific receptor of the sodium gauge to block the passage of the sodium ions. These are the theories of action of a LA, but not commonly asked these questions. But you must know about what are the theories of LA: acetylcholine calling theory, calcium displacement theory, surface charge theory, membrane expansion theory, and specific receptor theory. So, how will you take the LAS 1 V injection, oral, topical, and after that distribution and metabolism and through excretion? So uptake, the most LA produces vasodilation, and procaine is the most important for the vasodilator. Cocaine is the only vasoconstrictor. So the route of administration I already mentioned. There are different methods are there. Cocaine is well also orally, hepatic first pass, metabolism, and toconate hydrochloride. Tropical, topical route means on the surface leaving tracheal pharyngeal and injection by active intravenous intramuscular subcutaneous. So, what are the pre-convulsive signs and symptoms showing when you act early? First sign is that slurred speech, anger, shivering, muscular twitching, tremor in the muscles of the face and the distal extremities. And the symptoms showing is numbness on the tongue and the circum or oral region, warm, flush feeling of the skin, pleasant dream-like state, generalized light, visual disturbance, auditory disturbance, drowsiness, and disorientations. These are the signs and symptoms showing when you are giving LA. When you're giving broken, then oral and tongue numbness. That's a normal. When you're giving for inferior broken, normally we'll ask to the patient where is did any numbness on the tongue or region. These are the areas upper lip like that. Convulsive phase, when the carbon dioxide levels are increased, the amount of local anesthetic necessary for seizure is reduced, and the duration of resulting seizure is increased. For further increase in the blood vessel resulting in cessation of seizure activity. So electroencephalographic tracing become flatter and severe depression will be happen. So what is the absorption? How the absorption? The systemic absorption of injected local anesthesia from the site of anesthesia is determined the several factors that are including the dosage, site of injection, during the drug tissue binding time, and the local blood flow. These are the main factors that will affect on the absorption. Application of LA to highly vascular areas such as tracheal because of tissue surrounding the more rapid. So depends upon the blood flow and site of injection. The action will be absorption rate will be more affecting. So when you give on the tracheal, the surrounding, it becomes more rapid. So the diffusion, the amide local anesthesia widely distributed after venous bolus administration. After the initial rapid distribution phase, it considers uptake into highly perfused organs such as brain, liver, kidney, and heart. A slow distribution phase occurs with uptake into moderately well perfused tissues such as muscles and GIT tract. So, how will you the metabolism and excretion? The local anesthesia are converted anesthesia are converted in the liver, means amide, or in the plasma like ester type, to more water soluble metabolites and then excreted urine. Ester type LA is metabolized pseudocholinesterase, and amide type are hepatic microsomal enzymes and enzyme amidase. So mostly through converted into the liver and excreted to the. So what are the most side effects we can see in the cardiovascular means serious depression of the heart, brachycardia, hypotension, cardiac arrhythmias we can see. In CNS, in the brain, rapid absorption produce restlessness, tremors, convulsion. Sometimes the anaphylactic reaction commonly seen in the ester type and cause asthma, dermatitis, skin rashes, etc. And the corneal change, very rarely rosal corneal change can occur. It's very rare, but mostly what we have seen on the LA allergic is there, but it is an uncommon thing. The route of application already mentioned that surface anesthesia most popular. In the ophthalmology also it is we use, and also we using on the before giving LA we applying topical LA on the skin. Then there will be no any pain when you breathe then needed. So at that time we are using topical anesthesia we are used there. Liquid formation we used. Infiltration, anesthesia, and nerve endings are anesthesia by the direct exposure to the drug. Drug influence are potentially broken and lichenogen like 2%. Normally 2% lichenogen we are commonly used for the administration of the LF for the anti-block. Nerve block anesthesia drug is injected very close to the nerve brachial plexus. So for inferior nerve block, we are block the inferior nerve, long buccal, and tibial nerve. Spinal anesthesia is injured on the subarachnoid spaces, topical again. That epidural anesthesia is on the dual space. Spinal anesthesia and epidural not we are not using, but I mentioned about the spinal anesthesia and epidural. But the nerve block we are using for mandible we are using inferior nerve block and middle nerve block. Okay. For the upper blocks like gate binding, incisive blocks and posterior supra-ulnar block, middle supra-ulnar block like that. But according to our curriculum, we are studying for upper, we are giving only the infiltration, and lower we are giving infiltration and inferior ulnar block. So in the mentioned about the systemic actions of LA on the CNS, the anticonvulsive property. In the CNS, there is a depression will be there and a high level LA produces chronic convulsions. And mostly the broken lignocantins with the anticonvulsant property is there. For the cardiovascular local energy modify the electrophysiological events of the myocardial depression to see decrease the electrical excitability, rate of conduction, force of contraction, advantage, and hyperexcitable myocardial as broken and lignogen. So mostly on the preconceived signs and symptoms already mentioned, like the numbness of the tongue and all these things, excitation, or sedation for 5 to 10 minutes after the administration of local anesthesia. So the direct action on the myocardium and the peripheral vasculature increased LA, blood vessels, decreased myocardial depolarization and decreasing the myocardial excitation, decreased in the conduction rate or decreasing the rate force of contraction, produce hypotension. So the local tissue toxicity like skeletal muscle ability heal within 2 weeks. Uh, and the long-acting LA produces some more damage to skeletal muscles other than short-acting LA. So the toxicity of the LA depends upon the cause. The accidental rapid intravenous injection and rate of absorption such as very vascular site is mucous membrane. So the direct action on the peripheral vasculature, the vasodilation of hypotension, non-overdose level like slight increase of change in the blood pressure, overdose level that shows the profound hypotension caused by decreased cardiac output, myocardial contractility, and peripheral resistance. Level less like a cardiovascular collapse due to the massive peripheral vasodilation, decreased myocardial contractility. These are the main things we can see. So, factors reducing the toxicity depends on the recommended from the depth or to volume. And use low doses for the patient. You must know about the maximum dosage of LA for the patient. That is very we can inject the LA to the particular patient. So what's the advantage of local anesthesia? During local anesthesia, if the patient remains conscious, maintains its own airway, excellent muscle relaxing effect, and requires less skill compared to the anesthetic like general anesthesia, non-inflammable, less pulmonary complications, aspiration of gastric anesthesia may happen, less nausea and vomiting, conducted bowel abdomen and pelvic surgery, post-operative early discharge for the patient, less bleeding, expense is very less, ideal for the procedures until have a patient awake and cooperative. Local anesthesia is very for the uh, ambulatory patients having minor surgical procedures. These are the main things, and also for the there is advantages, then definitely there is a disadvantages. The disadvantages are mainly by there are individual variations in the response of the LA drugs. Rapid absorption of the drug into the blood can cause severe potential fatal reactions, and patient ability to see and hear increased ability. Some patients prefer unconscious and unaware direct damage to the nerve, post-dural headache from the CSF lead, not suitable for the extreme age. Multiple needle pricks may be needed, hypotension and bradycardia throughout the blockage of the nervous system. So these are the main things we notice uh, on the LA. And one more thing I want to tell you about that what's the maximum dosage of LA for the normal 62 centimeter? It is around coming around 11. If we are using linogreen, then normally we are using around 12 to 13 cartridges we are using. So if lidocaine here we are using with adrenaline with 1 is to 2 lakh or 1 is to 2% normally for a 60 kilogram body weight patient we can use normal around 12 kg. If it is a 1 is to 1 lakh like that, no, definitely we can give around the kilowatt kgs like that. Thank you. So this is the topic regarding about the pharmacology of LA.